So again, it's my great pleasure to discuss a couple of topics that are close to my heart, and one of them is virtual surgical planning, particularly because I think there's a thought out there that virtual surgical planning does away with a lot of the traditional planning that we all know about. And for all of our younger surgeons out on this talk, it doesn't forgive if you get it wrong. You know, just because you're doing surgical planning on the computer doesn't mean to say that you can forget all about the principles that you have learned before. The first part of the talk is on orthognathic surgery, and we all know what orthognathic surgery is. Ortho meaning straight and gnathos meaning jaws, or a harmonious relationship between the upper and lower jaws, important for aesthetics and function. Previously, we've relied on plain radiographs, lateral head, cephalometric x-rays, PA, KEFs, and the OPG. And with those, we planned our cases in a two-dimensional way, looking at how things may turn out and where people are at. We took study models. We did surgery on the study models. We mounted our casts on articulators. We moved things around. We did our model surgery. We created our intraoperative splints so that we could position our jaws where we wanted to go. And for those of us who have a few grey hairs, this was done often late at night or during the afternoons or on weekends, and took a lot of time. And I'm not so sure that we got the answer that we really wanted to get at these times. The limitations that this imposed on us were that the Frankfurt horizontal plane, which was pivotal in our workups, really perhaps was not the best plane for us to look at. It wasn't possible to view the entire data set in 3 dimensions. As I said, we had a 2-dimensional plane. We used a face bow, which, to be quite honest, was a hit and miss orientation as to how we orientated our casts on the articulator. The mounted study cast did not have a reproducible anatomical correlation to what you were doing. And so it was very easy, if you didn't understand the 3-dimensional structure of the jaws, to make some unusual movement on your model surgery. And in fact, I've seen some of my own trainees, and in fact, some of my own colleagues who have pushed the maxilla up only to find that at surgery, really, the movement is back, simply because of the 3-dimensional relationships that weren't understood. So the articulator is not really a true representation of our jaws. As I said, it's not possible to view the entire data set in 3 dimensions. And if you have a look at this gentleman, very large asymmetry, condylar hypoplasia or condylar hyperplasia, and we really couldn't tell on sometimes the radiographs that we were looking at. We could make a view that this was an asymmetry based on the lack of superimposition of the 2 sides of the jaw. So when we came to looking at 3-dimensional representation, we got a much better view of the way the jaws were. And in fact, it's almost impossible on the 2-dimensional x-rays to get this sort of representation of really what's happening with the jaws. You know, this one perhaps is a condylar hyperplasia on the right side and a normal growth on the left side. But it could easily quite easily be a condylar hypoplasia on the other side. Mandible study casts do not have a bony support. So therefore, there are great difficulties in the visualization of surgical defects. And as I said, lateral head predictions are inaccurate and time consuming. So virtual surgical planning, that was a very brief overview of what we had been doing. And I'm not saying that those things were irrelevant. They still have their place. Virtual surgical planning now is possible with the introduction of CT and cone beam CT scans. Our students need to understand that the clinical examination remains the same. CT scanning and cone beam CT scanning does not replace a clinical examination. And there's a tendency to make over-reliance on radiographic and other special investigations. We need to go back. Our patients still need examination. We look towards having both the CT scan, that's DICOM data, and also an intraoral scan or a scan of models. A CT scan will not give you the fine detail of the teeth that is required to look at occlusal discrepancies. So an intraoral scan with an STL file combined with the DICOM data will give you a composite skull model, as you can see in the diagram here. This model will tell you exactly where the teeth are, because that is a direct scan data, and the CT data then gives you the position of all of the bones. The deformity can be quantified using a different sort of cephalometric analysis. And this is usually a computer-generated cephalometric analysis. Our standardized 2D analysis are not relevant in these situations. Surgical movements can be planned and outcomes visualized. And as we become a little bit more sophisticated in the use of these plans, we can also use a soft tissue scan to superimpose over this hard tissue scan to look at how the soft tissues look and how they may look with surgery. Obviously, our bony changes can be predicted with a high degree of prediction. Our soft tissue changes cannot. And there isn't a way that we can easily transpose our hard tissue to soft tissue predictions. And soft tissue predictions will always remain somewhat of an artistic form in orthognathic surgery. We can use our 3D printing to look at printing intraoperative splints and patient-specific implants for positioning of the jaws. So pre-operative assessment now relies much more on the visualization of the structures rather than the numbers that are associated with that. So your clinical examination must hold hands with what you're seeing on the X-rays or the CT scans and the 3D renditions of those CT scans. And with it are a new group of problems. So we can selectively remove the mandible, the maxilla, the zygomas, in order to look specifically at the movements that those bones are making. After we have moved our jaws, we can then look at what has happened to the jaws in these movements, right down to the millimeter. That is on the CT scan. So as I can show you on this diagram here, the amount of overlap and the way that we secure these jaws in their new positions can be determined within the virtual surgical plan. We can remodulate the 3D structures and look at them in different planes. You know, turn it around and look at it from the back, turn it upside down and look at it from the worm or the bird's eye view. And I need to really say that we still need to understand what sort of movements are required. This does not replace your surgical skill. You need to have a very good idea of what is possible in surgical planning and what is possible on the surgical table. If you don't, you will find yourself doing all sorts of things that are not possible within the theatre situation. Again, you can really remove each of the components and have a look quite specifically, really where the jaws are going to go. Any interferences that you're going to look at, both on the teeth and in the bones. You can make yourself guides as to what you might do to help overcome those interferences or those difficulties during the surgery. And again, you can look at constructing these intraoperative splints. And these are as accurate as the splints that you would make in the dental laboratory that we formerly used. I was very skeptical about this to start with, but I have seen that these sorts of splints are as accurate as those that we make with our own hands or the dental technician makes for us within the laboratory. And that is important. So how has virtual surgical planning changed our approach to orthognathic surgery? In two ways, and in both of these slides that you can see, the first on the left side is the cutting guides that can be developed in the uncut maxilla. So before you start your osteotomy, the soft tissue cuts are made, the bones are exposed. This cutting guide is placed on the maxilla. This gives you a guide as to how much bone you are going to remove, where the bone is going to be removed, and most importantly, provides the guide for the final position of the maxilla. So that the final plate here, once you have the maxilla mobilized, can be utilized to place the maxilla into its position without the need for intermaxillary fixation and without the need for an intermediate wafer. And by doing this, some of the errors that occur in the construction of your intermediate wafer, some of the issues surrounding condylar seating are eliminated. And it also means that there may be an opportunity to do the osteotomies in reverse order. So you may be able to do the mandible first prior to the maxilla. I'm putting this in for completeness, but I need to let you know that I do not use mandibular cutting guides. I do not find that these are useful at all, only because of the amount of stripping that you need to do on the mandible to put these guides in place. If you put these guides on, you have to strip really the entire mandible. And I don't think it's useful to be able to put these on and make your cut. The cut is where you put the cut. And a sagittal split can be done without the need for a cutting guide. And I think these cutting guides for the mandible complicate the procedure far more than they simplify it. So just some clinical cases here. This is a young man with the cutting guide in place. And as you might already notice, this is one of our early cases where we also used intermaxillary screws just in case we had some issues. And surgeons need to understand that should something go wrong with this planning, they need to be able to troubleshoot and get themselves out of the problem if there is indeed one. You can see that the incision is probably a little bit larger than we're normally used to in orthognathic surgery, but the cutting guide gives you a very precise guide as to the amount of bone and the position of the bone that you're trying to remove. And following the osteotomy and the down fracture and the mobilization of the maxilla, this plate can then be placed on the maxilla to position it in the correct position without the need for condylar seating, without the need for intermaxillary fixation. And again, when we first started, we looked at using intermediate wafers and intermaxillary fixation to check really what we were doing. We've now done away with intermediate wafers. We have done away with intermaxillary fixation and rely 100% on the position of the final positioning plate. Again, as experienced surgeons, that's fine. But as inexperienced surgeons, you need to have a backup plan should something go wrong. This is what I was talking about with the mandible. The amount of soft tissue stripping from the mandible, I feel, is far too much. And this is not essential for a sagittal split osteotomy. There is no reason to place a cutting guide for a sagittal split. I think most, if not all, oral maxillofacial surgeons can perform a sagittal split of the mandible freehand without the need for a cutting guide. Where a cutting guide is helpful is in the where you're having to set back a mandible and you need to remove a piece of bone. And there you can see with the cutting guide and the holes made, the plate fits very nicely where it's supposed to be. And the final occlusion after the bimaxillary osteotomy, again in the pre-planned position. And this now can be done without the need for intraoperative intermaxillary fixation and without the need for intermediate wafer. As I said, as time has gone by over the last few years, I have gone back to a final wafer, and I will do my sagittal split osteotomy freehand and use a final wafer and intermaxillary fixation to determine the position of the sagittal split. I think that is far more effective in my hands than it is a cutting guide and a positioning plate. So what are the advantages of a VSP protocol in orthognathic surgery? We have a far greater potential for evaluating treatment outcomes. However, we need to balance that against the radiation exposure that these patients may have. These sorts of scans allow a greater facilitation of communication with patients and a greater understanding of the sorts of procedures that you're going to do. The computer-aided design and computer-aided manufacture of splints is perhaps more accurate than handheld models or mounted models. There's certainly improved diagnosis of facial asymmetry, and there is a reduced time involvement for both patient and surgeon and a lower material cost. However, the cost of virtual surgical planning in our country is exceedingly high. And we're having discussions in trying to determine why the costs of this are so high. In fact, the cost of sometimes a virtual surgical plan in orthognathic surgery is greater than the cost of providing the surgery. And this is very important in that somebody has to pay for this. And we can do this, you can do it yourself, in fact, which will bring the cost down, but obviously the labor involved in that and the skills, the intellectual property skills that are involved in that are also very high. Clinical examination of tissues is still required. I cannot emphasize this enough, that we must ensure that we continue to provide a great clinical examination. And if we're going to pass that on to our trainees, they need to understand that the very beginning starts with a clinical examination. The soft tissue prediction, as I said, needs to be improved. The algorithms that look at this show that the algorithms that are used are not, they do not provide a good prediction. And that is due to the research that we have in this. A good centralized planning facility that is low cost should be developed. At the moment, the companies that are providing the patient-specific implants are also running the virtual surgical planning. And that whole package is tied up with costs. The CT scan cannot appropriately capture the occlusal surface of the teeth, so the patients need to undergo a direct scan, a direct intraoral scan of the occlusal surface of the teeth, and that has to be combined with a different computer program with the DICOM data of the CT scan. And we need to be able to reduce the radiation dose, because we cannot, like we used to do with plain X-rays with OPG and lateral head, we cannot follow people with CT scans because the radiation dose is just far too high in these areas. So the accuracy of virtual surgical planning was something that we looked at. We did a study here in Adelaide, and we aimed to compare the three-dimensional surgical prediction with the post-operative surgical positions of the orthognathic hard and soft tissues. We had certainly ethics approval, and as I've said before, we were very concerned about the radiation dose, and so we used 3 scans: a pre-operative scan, an immediate post-operative scan, and a 6-month scan to compare each of the various aspects of the treatment that we were providing. We had 20 private practice patients. 17 completed the protocol. 3 dropped out either because they did not wish to have the 6-month or immediate post-op scan, or some other factor. They were just lost to follow up. They were aged 18 to 70. The 70-year-old was a person undergoing jaw surgery for sleep apnea. All received orthognathic surgery from a single operating surgeon. That was one of my colleagues. We had a preoperative low-dose dental CT scan taken in centric occlusion, a clinical bite record. We didn't have the opportunity to use an intraoral scanner, so we used dental study models and scanned those. We uploaded the DICOM data to Materialize, and thank our colleagues at Deploy Synthes. We created a virtual skull model by a clinical engineer, and then looked at condylar position based on the clinical jaw relations that we had. And then the surgeon and engineer worked together to plan surgical movements. And this is very important, because a lot of the engineers, although they have a lot of experience, did not fully understand the movements that can occur with orthognathic surgery. It is very important that the engineer works with the surgeon, and the surgeon directs the engineer, not the other way around. We obtained DICOM data, immediate post-op, as I've suggested, to assess fixation and positioning of hard and soft tissues, and at 6 months. We then were able to use the CT scans and color them different colors and then overlap to compare the virtual surgical plan, the immediate post-op CT scan, and the 6-month scan. And then we looked at a statistical analysis to establish which of the landmarks observed were significantly more variable between those 3 levels and between the accuracy of single and 2 jaw surgeries. So ultimately, the 17 subjects that we had were 18 to 61. The man with the sleep apnea fell out. He did not wish to have further CT scans. We had 12 female, 5 male, 5 maxillars, 4 mandible onlys, and 8 bimaxillary. So about half and half. And again, we looked pre-operatively, we looked post-operatively. We did a standardized protocol where we both had splints as well as positioning plates, as well as the opportunity for intermaxillary fixation. So we looked at overlap assessment between the virtual surgical plan and the immediate, and found that really the variance was less than 2 millimeters, certainly versus the maxilla and the bimax, and the mandible versus a bimax. And the single jaw procedures showed more consistency than the bimaxillary procedures. The bimaxillary procedures were significantly different to the mandibular procedures in terms of the virtual surgical plan prediction. And again, the maxillary landmark variance of single jaw surgery was around about 2 millimeters, and the bimaxillary surgery a lot less at these points. So A point, anterior nasal spine, and of course anterior nasal spine is often part of your osteotomy. So again, it was a landmark that was difficult to look at. And again with the mandibular, but we found that really the variance between our virtual surgical plan and the immediate and longer term follow-up was not significantly different between the virtual surgical plan and what we actually found. So the limitations that we really came up with was that if the patient was not in centric occlusion, or the condyle was not seated during the preoperative imaging, then all of your movements were not going to be significant. They were going to have errors in them. So this was the addition of that third dimension, which gave us a greater variance, and that is the yaw of the jaws, the change of the position of the jaw, not in the lateral plane, not in the sagittal plane, but in the lateral plane. Condylar seating during surgery. Again, this can be an issue. The surgery was done by a right-handed surgeon, and the left side showed greater variance. And we put this down to the dominant hand of the surgeon standing on the right side of the patient. No matter how accurate
no, American. She's down be any organized. No,
there's some background noise on the so condylar seating during surgery.
Sorry, Prof. Sambrook, please everyone make sure that your mic is unmuted, on mute state, please. I think you can continue now, Prof.
Thank you, Dr. Magani. Thank you very much. The plate adaptation during surgery sometimes wasn't 100% accurate. And no matter how accurate your planning is, it still does not replace intraoperative skill. So you need to be able to get yourself out of a pickle, should you need to, during the orthognathic surgery. The dentition may have moved between the preoperative scan and the surgery, and that's an issue that we all had during the construction of our splints, even in the past. You know, that if there was a long delay or there was active orthodontic treatment, then unfortunately your wafers were not going to be accurate. And we had a small sample size here, so we're not trying to make great definitive statements here, but really it was just an indication of the sort of things that may be an issue with the VSP. So this protocol provided a simple and viable method of data collection. We found that it allowed reproducible recording of jaw relations, a clinically acceptable outcome, and VSP, due to accessibility, may well be the way of the future for orthognathic surgery. But it doesn't, again, stop the need for in-depth planning that we need to do ourselves. We should be able to reduce the number and complexity of preoperative appointments, reduce laboratory time. Apart from the study here, we should be able to reduce the number of radiographic exposures and produce clinically accurate outcomes, as opposed to when we were doing this you know, by hand and by our own laboratory things. So here's a young man, just to show you through a case. You know, his initial models very early on, and as he grew, developed this asymmetry. So pre-op scans showing the obvious asymmetry. The virtual surgical plan for him, including the fabrication of cutting guides, showing exactly where the movements would go. And then the performance of the osteotomies beyond there, and the occlusion that was developed. So again, it just made, in experienced hands, the development of the splints and the surgical plan to be a very straightforward type procedure. And in the surgery, likewise, exposure, and this is what I was saying about the anterior nasal spine, very variable part of the operation where you may cut the spine off. I keep the spine intact, but remove it from the maxilla so the muscle attachments are attached. Placement of the virtual surgically planned cutting guide. And then placement of the final splint. And we checked this as I said, and then the mandible was cut likewise to the guide that was there. And again, looking at the movements that were performed here. The other thing that this program attempts to do is look at occlusal interferences with the teeth. I do not remove these interferences. I wait until after the occlusion has been developed, after the post-operative orthodontics has really restarted, and then look at the interferences. So I don't believe in removing these interferences at the time of the surgery. Again, the soft tissue envelope is not a great way of of looking at these because the CT scan does not predict soft tissues very well. So this is the sorts of things that we were doing. We were looking at the pre-op, the planned, the post-op, and then looking at the planning and the post-op and looking at where in superimposition these may have changed. And these differences in the planned and the post-op on the whole were less than a millimeter. And so from the initial virtual plan to the initial surgical plan, these turned out really, really well for that. And so virtual surgical planning really is an adjunct to the diagnosis and treatment planning of our orthognathic surgery patients. They will never replace the artistic skill of the surgeon, and they will never replace a good clinical examination. Following on from that, we looked at how we might use virtual surgical planning in oncology and reconstruction. And really, we can get to a position in orthognathic surgery a number of ways. But really, virtual surgical planning has revolutionized the management of oncology and reconstruction with microvascular flaps. And I get asked by my hospital, we do have data on this, what are the advantages of using patient-specific implants and virtual surgical planning in terms of oncology and reconstruction? There is no doubt that there is a reduced operating time. There is no doubt that there is a reduced average length of stay as a result of that reduced operating time and reduced morbidity in terms of the oncologic resection and oncologic reconstruction. Although cost is an issue, in general, the costs that are realized in terms of reduced operating time and reduced average length of stay more than compensates for the cost of the virtual surgical plan. And unlike with orthognathic surgery, there are many ways to look at virtual surgical planning here. In its simplest form, a virtual plan for oncology could be the construction of a three-dimensional model. Very straightforward to do with a 3D printer and just your straight DICOM data. You take your CT data, you clean it up, you print out a model. You can do the equivalent of the model surgery on the model, and you can bend a plate on the benchtop, get that sterilized and remove, take it to the operating theater. So it doesn't have to be all of this fancy things that we do. It can be as simple as that. Your virtual surgical plan can be very, very straightforward. And you can remove the tumor as part of your manipulation of your data, and then construct a 3D model and then pre-bend your plate. We don't have to have these fancy CAD/CAM sort of plates that are made. In its most complicated form, in oncology, you can have cutting guides, inset guides, everything pre-printed. So you don't need the models then, but you actually just need all of the guides that go with it. Unfortunately, if you only have the guides, if something goes wrong with a guide, then you're going to have to freehand it. So you need to be able to perform the reconstruction without the need for a guide if things happen, and things will happen more often with oncology than they will with orthognathic surgery. With oncology, the tumor may have grown. The soft tissues or the blood vessels may not be exactly as you had planned. You may find that there's a fracture in your graft that you weren't aware of. You may find that all sorts of other things that can happen that make this even more complicated than it could have had before. So these are the reconstruction options that we use within our department here. Obviously, straight soft tissue flaps, we do not need or use virtual surgical planning. There is no need for that. It comes into its own with bone and composite flaps, particularly workhorse flaps are the fibula and the scapula and the iliac crest, and mainly the fibula. So this is just an option for us, and this one we remove the mandible. We pre-bent this plate prior to placement on here. Still used a free flap, but then fashioned our free flap to the plate rather than using cutting guides. So this wasn't something that we had printed, but we made this on the bench from a model made from a 3D model. This one, very different, a double-barreled flap using patient-specific implants that were constructed after virtual surgical planning. And this one, being an ameloblastoma, was a little bit easier to construct. It wasn't a large, rapidly growing squamous cell carcinoma or other malignant condition. So if we take a couple of examples here, squamous cell carcinoma, anterior mandible, CT there showing the bony destruction. So this is the computer-generated model from the CT scan, outlined with what we had planned to remove. Again, these are not diagrams. These are from the scans showing the fibula with this blood supply, so that we can ensure that we have a good blood supply, firstly, and secondly, we can determine the best place to take the fibula from. And this is being colored in this way because of the way it's going to be placed into the mandible. Perhaps the engineer is able to look at the mandible here. So this is a slightly different case, but the same principle applies, where we need to cut out this. We need to be able to place the fibula in this sort of configuration to be able to reconstruct that mandibular arch. And if we go back to our previous one, you can see the blue and the green are where the fibula was going to be placed within the mandible in relation to its blood supply. And the engineer will then give us a cutting guide to cut the fibula here before we cut the blood supply. The fibula is already fashioned, and the reconstruction plate is already put on the fibula before the blood supply is removed from the leg and before it is plumbed back in, to minimize the amount of time that the fibula is avascular. And here we can see the fibula in place, and those two segments that have been placed there. As you can see here, the other holes here are the cutting guide that we use to fashion this fibula, and you can see the holes here where the cutting guides were attached to the mandible when we removed the piece of mandible in the tumor resection. And this is the Doppler that we use, a Doppler for flap viability. And here we can see the final result. So we can also look at how we might place the mandible within the bone that we are taking. So the resection, a large amount of bone, 54 millimeters, 57 millimeters. And as you know, this could probably be done with a free bone graft, with a non-vascularized bone graft. But we have the surgical skills to put a free flap in these ones. And so we've tended to put a free flap despite the fact that we might be able to get away with a non-vascularized bone graft. We just find our results are a little bit better with our free flaps here. We can then take the mandible and place it overlying the hip to see where that piece of bone might come from to be able to place within this defect. The cutting guides placed so that we have our exact defect that we're going to be looking for. The hip marked out, including the blood supply, the bone harvested and placed within the defect of the mandible. Again, you can see the plate in its pre-programmed position, in the position that the virtual surgical plan has given it to us. And this is one where we are now placing dental implants into the graft before it's been removed from the hip. So we can plan implants into these sorts of transplants in order to reduce the number of surgical procedures that these patients undergo. And oftentimes these people have procedure fatigue. They will have their cancer resected, they will have their reconstruction, they will have their radiotherapy, they will have all sorts of things. By the time you come to try and reconstruct their dentition, they've had enough of you. They don't want to come back. And so if we can try and do the maximal reconstruction at the same time, then we have started doing that. And there are some of our colleagues that would suggest that, you know, there are a number of these implants that may never be restored, and that may be so. But I think the quality of life that we can provide these patients now with some of the reconstructions that we can give far outweigh the odd implant or two that is never used. And immediately post-operatively, and as I've suggested, we can look at you know, pre-planning implants into these areas and putting implants so that the patients have a very good reconstructive option. Again, another large ameloblastoma in the mandible. Looking at a fibula this time, or a hip, and we're trying to determine what we might use for this particular reconstruction. Again, just overlying each of these reconstructions on the particular bones to see what would provide the best option. And these overlays are really interesting, really a good opportunity to see, you know, what is the thickness of bone, not just a two-dimensional reconstruction. In the past, we thought we were doing really good reconstructions, just filling a hole with tissue. That is no longer the standard of care that we need to be aiming for. We need to be looking at replacing the masticatory apparatus. That means teeth, bone, and soft tissue. Sometimes we can't, but if that is our aim, you know, we should be able to look at doing that. As you can see here, this reconstruction would realize that the graft transplant is placed far too buccal for us to use for decent reconstruction. It needs to be inset further. And again, these are the sorts of things that you need to be able to discuss with your technician, with your computer technician that's going to do these things for you. That even though the lower border here may well be a really good thing, if you look at the way the mandibular teeth on the right side are inset, the left side here needs to be inset even further. Maxillary reconstruction, even more complicated, simply because the three-dimensional structures, the nose, the sinus, the orbit, the zygoma, all are really difficult areas to look at. And this man had a large sarcoma in that right maxilla. And again, if you think about that, in the past, we've either obturated or put a temporalis flap in there, replaced it with soft tissues, or nothing at all. And again, looking at functional reconstruction, we need to be able to follow these patients, but we also need to look at functional reconstruction for these sorts of people, so that we have a mixture of bone, soft tissue, mesh here for reconstruction of that orbit, orbital floor, to ensure that this patient has the most optimal reconstruction of their masticatory apparatus. So this one is a scapula. And again, the three-dimensional look at the scapula here, in the past, to try and freehand that is very difficult for a very experienced surgeon. You have to take a large amount of scapula, bring it in. There's lots of fiddling about, lots of refashioning, trying to put it in, never quite getting it right. But with this, you can cut it to the correct spot. Unfortunately, with this particular case, this just exposing these areas around the zygoma and zygomatic arc was very difficult. And so even in setting this patient-specific plan was difficult to do. And we had to refashion this graft and not use a couple of these patient-specific plates in this case. Again, the final result here, a very acceptable result in terms of reconstruction of that defect. No oroantral or no oronasal fistula, preservation of eyesight, and we can look at some sort of prosthesis coming up for that. So virtual surgical planning in oncology gives us the opportunity to do a much better and fairer reconstruction for our patients, really trying to give us a good opportunity to reconstruct their entire masticatory apparatus, breathing, eating, and speaking, and hopefully improve the quality of life that these patients have for the rest of their life. I must acknowledge the other members of my team in Adelaide, Dr. Andrew Cheng for the Orthognathic side of things, and Dr. James Badlani, who does a lot of our free flaps and some oncology work for here. I thank you for your attention. That's the first part, and